All right, it's 6:30. I think we're going to get started. We'll see if more people straggle in as we go along.
Yeah, I
But
think is Marco recording this as well?
I believe so, yes. Yeah,
Okay, good.
looks like it's going. Yeah. All right, so this is going to be a webinar on hemorrhoids, and my name is Dr. Ari Isaacson, and I'm joined actually today by Dr. Alex Poitapa, who's on as well. And as we go through, if anyone has questions, feel free to type them in the chat, and Dr. Puitapa can respond as I'm talking. Just to get started, a little bit about me. I'm an interventional radiologist. That's my specialty. If you're unaware or, what interventional radiology is, it's a subspecialty of radiology, but instead of interpreting images like a diagnostic radiologist, we perform procedures using some kind of imaging. And a lot of times it involves catheters in arteries or veins. And so that's how we got to hemorrhoids here. And we'll kind of get to that in a second. I used to be on faculty at UNC. I was there for 8 years. I did a lot of research while I was there on procedures like the one we're talking about today. And now I practice at IR Centers, which is part of the Associated Urologists of North Carolina in the Briar Creek area. So let's get started with the hemorrhoids. And so just a little background on hemorrhoids. Obviously, a lot of you know that it's a very common problem and affects a decent part of the population. Um, I wanted to start by just kind of doing a little anatomy here and differentiating between two different types of hemorrhoids. So and there's internal hemorrhoids and external hemorrhoids. And you can see from this diagram here that the internal hemorrhoids occur within the rectum. Now there's a line here called the dentate line. They start above the dentate line and they kind of sag down. And a lot of times they prolapse or they sag all the way out of the anus and can be seen or felt out of the anus. As opposed to external hemorrhoids, which occur more towards the skin here, and they have a completely different blood supply. And they also have different symptoms, and we'll talk about that a little bit here. So let's start with external hemorrhoids because that's not really going to be our focus, but I do want to just mention a little bit about them. So those, as I mentioned, are usually on the skin, and they're you can feel them as lumps. They're engorged venous structures, and they are associated most commonly with pain or itching. And those are the kind of hemorrhoids that people might use sit in a bath and use like a sitz bath or put preparation H on, and they can be treated with topical things most of the time. But that's not really what we're focusing on here. We're going to focus more on internal hemorrhoids. And so these are vascular cushions or venous structures. And they, like I said earlier, they fill and become engorged. And when they become engorged, they sag down and they can often bleed. And that's really the most common problem with the internal hemorrhoids. So what are risk factors? Why do people get hemorrhoids? Well, one big one is pregnancy with women because of the increased pressure while delivering a baby. That can cause those structures to become engorged, and then that becomes a problem for a while after pregnancy. Constipation is another big one. If you're constantly straining to have a bowel movement, that can also result in hemorrhoids. And then if you do a lot of power lifters, if they're really pushing to lift, that can be another risk factor. If you eat foods with low fiber, so a lot of meat, not a lot of vegetables, that also can cause hemorrhoids. And another one actually is if you actually sit on the toilet for a long period of time while you're having a bowel movement, people who read or whatever on the toilet and end up sitting there for half an hour, that's another risk factor for developing these internal hemorrhoids. There is a classification system that we like to talk about, and it's relevant because it affects what the treatment is. And really the classification has to do with the prolapse or how far out the hemorrhoids are protruding. So if you have a grade 1, which is the most mild form, you have a hemorrhoid that's still within hasn't come out of the anus, it can bleed from this position, but it's not sticking out. A type 2 will stick out, but it will also go back on its own. It doesn't require being pushed back in. It will just kind of go back in on its own. Whereas a 3 does require a manual reduction, or someone putting their finger in and pushing it back in. And the grade 4 is the most severe, and that actually is fixed. It cannot be reduced. It's stuck in that prolapse position. All right, so what can you do? What are the conservative measures before you even think about a procedure for these hemorrhoids? And so initially, the first thing to do is to increase your fiber intake and increase your fluid intake. Stool softeners and laxative can also be helpful. And then changing some of the behaviors. Avoid things that require straining if it's something you're lifting heavy, something like that, or again, sitting on the toilet for prolonged periods. Those are things that just can changing your behavior can help fix those hemorrhoids. Now, if those measures or those actions don't work, then the next step is usually people go to a gastroenterologist and they're offered some of these treatment options. These are a bunch of different options that are available through gastroenterology, and I'm just going to go through a few of them just for background. So we're going to talk with rubber band ligation because this is the most common thing that patients will get done to treat their internal hemorrhoids. So what this involves, it's a transrectal procedure. So they'll go into the gastroenterologist's office, and through the rectum, a device will be placed, which will basically kind of capture the hemorrhoid either with a forceps or with a vacuum device, and then we'll place a band around the bottom of it, strangulating it so that the blood can't get into it, and then that causes it to be starved of blood and eventually slough off or fall off. And I think I have a picture of that here. Yeah, so here you can see that exactly. Here's the device going through the anus. This one happens to be a vacuum device. It sucks in the hemorrhoid right here and applies this band on the very top of it, which then strangulates it, and eventually it sloughs off. Now, this is it is an effective treatment, and it's a common treatment, but there are a few issues with it. If someone's on a blood thinning medication, it's not necessarily recommended. It's good. We know we talked about the grading system just now of hemorrhoids. It's good for grade 1 and 2 and maybe some 3, but not 4s. And the studies kind of vary on how well it controls bleeding, anywhere from 60 to 97%. And there is a pretty high recurrence rate, about 10% in 2 years, and by 4 years, it's about 50%. What about complications from banding? So it can be painful. In rare occasions, it can get an infection and abscess formation. And there's a few others too, bleeding. It usually has to happen in more than one session, so it's not like a one-stop shop. You have to go back a couple times at least, if not 3 or 4 times. This is another option that the gastroenterologists have for the office. Again, it's a transrectal procedure, but instead of using the banding device, they use infrared radiation to basically cause the tissue to necrose and then fall off. Not as common as the banding procedure, however. Now this is another procedure that can be done, and it's interesting because it kind of leads us to what we're talking about. This is a device that goes in through the anus again and uses ultrasound to identify the hemorrhoids, and then causes them to either be photocoagulated using a laser or to be ligated using a suture. But what they're ligating is not the hemorrhoid itself. What they're ligating is the artery that is supplying the hemorrhoid. And this is important because this is the foundation of why we do the procedure that I'm going to talk about in just a minute as interventional radiologists. The last resort, if none of those things work, is surgery. It's hemorrhoidectomy, and it's not a pleasant surgery for the patient. It can be very painful, and so it's a good thing. It's kind of considered the last resort. And there's about 10% of patients with hemorrhoids that end up requiring surgery. All right, so now that we talked about some of the other procedures that are available, I want to go and start talking about what what we do. This is a relatively new procedure, and it's called Hemorrhoid, which is a combination of two words of embolization and hemorrhoids. And it's somewhat the equivalent of what I was talking about, ligation of the artery, but instead of doing it through the rectum, we're going to puncture through the artery like we would if we were doing a cardiac cath. All right, so just quickly from an anatomy standpoint, those structures, those kind of engorged endovascular or anal cushions that cause the hemorrhoids, are fed by these little arteries called corpus cavernosum recti. And so that's what we want to target. We want to target the arteries that are bringing the blood to the hemorrhoids and shut off the supply and then cause the hemorrhoids to shrivel up. And this is a diagram, and this is an angiogram. So this is an X-ray picture that has been taken after injecting contrast dye. And so you can see what these actually look like when we see them on X-ray. Now, I'm going to go over a little bit of the background, the data here. This was first described in 2015 in France, and they did this technique and showed that they could be successful 72% of the time in the initial run, and that was the clinical success, meaning they got bleeding to stop, and 100% of the time they were able to complete the procedure, so that was technical success. Since that time, there have been many more studies that have been done on this procedure, and now there's enough data to put together a meta-analysis, and the cumulative clinical success is closer to 80% at this point. And we know from several studies that we can do this a little bit better by using certain materials to close off those arteries. The most common material is an embolic coil, which is a little piece of platinum that goes into the artery and causes it to be occluded or shut off. But we know that if we take coils and we add these spheres, little tiny particles that look like sand, if we put some of those in first and then put coils behind them, we can increase the efficacy of the procedure. All right, so how is this procedure performed? Well, here's a little video that's going to show you what we do. The first thing we do is get access into the femoral artery, right? And then we run a catheter up to the aorta and into what's called the inferior mesenteric artery. We then put a microcatheter, which is even smaller catheter, and run that down to the arteries that are supplying blood to the rectum. Once we're in that position, we identify the corpus cavernosum recti arteries that are supplying the hemorrhoid with blood, and we inject those little particles followed by a coil. And what that does is it causes the hemorrhoid to shrivel up and no longer push out through the anus and no longer bleed. So that was a little movie representing what it is. These are actual pictures from the procedure. Again, we're using moving X-ray or fluoroscopy. And we can see in this image right here, this is called the superior rectal artery. This main artery right here is supplying blood down to the hemorrhoid, which is down at the bottom. So the catheter goes down and deploys those particles, and then this coil, which you can kind of see right here. And once we do that, the artery is no longer, the blood is no longer able to pass through this artery, and you can see there's no longer this contrast dye in the blood down in the hemorrhoid area. So we basically shut off the blood supply to the hemorrhoid, which causes the hemorrhoid to shrivel up and no longer bleed. So I'm going to show you a case. This is a 74-year-old female, and she's had symptoms for somewhere between 10 and 20 years, and she bleeds quite frequently, almost daily, from her hemorrhoid. Not really painful, but the bleeding is very bothersome. So here's images from her case. What we're seeing here is a catheter that's come through the femoral artery and is now in the inferior mesenteric, and we've injected contrast showing the course of this artery. We're now going to put in a microcatheter and advance it down to the bottom. Here's another, some more images from an injection of contrast, and now we can see these corpus cavernosum recti arteries down in this region on the right side of the screen. And so the next step is to go block those. So here's a still image showing a coil in place. And here's that coil again. And now you can see there's no longer blood going down there. Now we've taken care of this side, but we usually do both sides. However, in this particular patient, This artery is not supplying a lot of blood down to that area where the hemorrhoids are. So we need to look at another source. And so we've gone down to a different, the middle rectal artery that also supplies blood to that area. And we're going to evaluate that to see if that's supplying blood to the hemorrhoid. And when we do this angiogram and inject contrast dye, we can see a very large artery and a lot of blood down here in the areas of the hemorrhoid. And so the next step then is going to be to put another coil and particles down in this area. And that you can see that here. And now that stopped that blood. And now there's not nearly as much blood getting down to that area. And therefore, the hemorrhoids are going to shrink and no longer bleed. So after her procedure, her symptom score went way down and her bleeding score went way down as well. And her quality of life improved quite a bit. So a little bit about the patient experience when someone has this procedure. We do it in an outpatient center. Our center is located in Briar Creek, right near the airport. And it's not a painful procedure, so we keep the patients awake for it. We do give a little Valium just to relax people, but we don't put anyone to sleep. The procedure takes anywhere from about 30 minutes to 60 minutes, depending on how difficult it is to get our catheters into position. And after we're done, we close up the hole we made in the artery, and then patients lie flat for 2 hours to reduce the chance of any bleeding from the puncture site. There's really no downtime after the procedure. We do give one main restriction. We don't want anyone to lift anything heavy for a few days. So we'll say no lifting anything heavy for 3 days, but you don't have to be in bed. You can be up on your feet doing things. And there's really no pain as opposed to other procedures we do. There's almost zero pain after this procedure. The bleeding tends to stop within the first week afterwards. You can have 1 or 2 episodes after the procedure, but it tends to stop within the first week. Occasionally, we do have to repeat the embolization. It's pretty rare, but we do on occasion bring someone back to do it one more time. And this procedure is covered by all insurance companies, including Medicare. And so that's not an issue. And we are in network with every major carrier. So that's also not an issue. So here's our information where we are. And I think at this point, if anyone has any questions, feel free to type them in.
I don't have any
Or
questions right now in the chat.
I put all the attendees are now able to unmute if you wish and you want to ask any questions. And if not, we'll just, Alex and I will. Alex, you have any comments? Anything to add?
No, I think that was great. I think when it comes to, at least in our experience, our clinical success, we have the largest data or the largest study for data or clinical outcomes for this procedure. It's now probably over 300 patients, and our technical success is over 99%, and our clinical success is probably around 94%. And
Wow.
recurrence rate at a year is less than 10%. It's probably about 5 to 7%. And one thing I'll say, because like you had that slide in there about recurrence after rubber band ligation, it's very variable depending on where you look at the literature. In the Hubble study, which that was comparing rubber band ligation to Doppler guide ligation, that had like 370 patients that had a recurrence rate in the rubber band ligation up to 49% of the year. So the range is somewhere between 10 and 49%, which is a huge range. So that's one thing that I'd really want to point out.
Yeah. Okay. Just for background, Dr. Poitapah works in Virginia, in the DC area, and he works at a location that's called Hemorrhoid Centers, and they do primarily this procedure. That's what's done every day. So he has a very large experience doing this, probably one of the largest experiences in this country. So let's see. So how about Alex? Let me ask you a question.
Sure.
In your practice, so you work with gastroenterologists. What's their how do they think about this? If a patient comes in to see them with, say, a grade 2 or grade 3 internal hemorrhoid, Um, how are they determining whether they send the patient or they refer the patient uh, for an embolization or they do a banding at their location?
So I would say in the beginning, it was probably a lot more mixed on which patients they would send to us. But I think now they'll send any patient who kind of really fits that criteria. Even if they're interested in banding, they'll say, well, there's this other option. If you're interested in learning more, we'll send you over here just to have that conversation. So I'd say vast majority of patients who have symptomatic hemorrhoids, specifically with bleeding, that are grade 1 through 3, they'll at least send a referral or offer a referral to speak to us. Now, some of those are banding naive patients. Some of them have already underwent rubber band ligation. But most patients with hemorrhoids are at least offered to speak to us now.
That's great. So I think, some people may ask, well, this looks like a great procedure. It's not painful. Why isn't this being done for everyone who has hemorrhoids instead of the banding? And just to speak to that a little bit, I think, one of the issues is one, it's the awareness isn't there. That's why we're doing this. We're trying to get the awareness out there. And two is that, the gastroenterologists know what they do. They do banding and other things. And they don't know as much about what we do. And so that's probably the reason that not every patient knows about this procedure out there. But hopefully, as we move forward and more gastroenterologists become aware of this, there'll be more referrals for this procedure. It's really a great option for internal hemorrhoids.
Yeah, absolutely. And I think so. I think that awareness is coming. I think so. You were one of the pioneers for PAE. You're a pioneer for this procedure. This is probably where PAE was maybe like 10 years ago. Like this year, we spoke or we presented our data at the American College of Gastroenterology or this past October, and they gave us an award for outstanding research. So I think, eventually it's going to get there. It's just like anything else with innovation, it just takes time.
Yeah. So we're giving the opportunity for all of you listening out there to be on the cutting edge of hemorrhoid treatment and to be able to um, experience a treatment option that's kind of more benign than some of the others and be on the forefront of that. All right. Well, if there aren't any questions, then what we'll do is we'll call it a night for tonight. And there's the contact information on the screen if you want to call and ask any other questions or schedule a consultation. Feel free. And I want to thank you, Dr. Puitapa, for joining us and chiming in. I appreciate it.
Thanks for having me, Ari.
Yep. All right. Good night.